Um, our normal grand rounds format is that I will often start with what I call the neurosurgery's chair's corner, allowing me to talk about what I think is important for the department and in neurosurgery. If this type of format works, I would propose that we would switch on and off and allow other chairs of other departments to give their perspective for each grand rounds that we share and participate in. And maybe it wouldn't be every week, but as we collaborate with departments around the world, it would be very interesting to get their personal perspective from the chair of other major departments as to what is important for them. It's a bad time in the world, and it's a really horrible time in neurosurgery and a tough time for me personally. This weekend, we lost one of the shining lights of neurosurgery with the death of James Tate Goodrich, the chief of pediatric neurosurgery at Montefiore Medical Center, and a dear and old friend of mine, personal friend. Jim contracted the coronavirus and rapidly progressed to multi-system failure, and he died despite heroic efforts over the weekend. As someone once recently told me, they don't make them like they made Jim Goodrich. This is a man who took a year off during school to go surfing as a surfer dude in California. He then became a decorated Marine serving in the Vietnam War. He went back to school and obtained his PhD as well as his medical degree and became a neurosurgeon. As a neurosurgeon, he rose to great heights. He became internationally famous when he did some of his craniopagus separations, but he was an erudite scholar, an incredible human being, a dear lover of great food and wine, a consummate educator.
Dr. Batterson, I just want to note, we're looking at the presenter view. If you maybe make it full screen, we'll be able to see the full screen rather than the presenter view. Okay, that's perfect. Thank you.
And here you see Jim teaching. He had one of the best historical book collections in the world, particularly relating to medicine. Each year he would present at the New York Society for Neurosurgery. At the Ellsberg Lecture, he would present a historical book to the winner, and here you see him giving Cal Post the honorary book in 2015. He was a doctor's doctor. His patients always came first, and here you can see some of the twins that he treated. Naturally, this occurred in his home, and in his home was one of the most remarkable two-story libraries straight out of Harry Potter, with collections from his travels around the world. Jim was a consummate collector of history, of books, of items, and a dear personal friend. We shared many wonderful moments together at my home, at our home, and in his home. His wife, Judith, was always by his side, and I can only imagine what she is going through right now. So I just wanted to take a moment to reflect on the personal toll that this is taking on all of us. In the midst of this, we have to respond. And I will use the next few minutes just to go over what we are doing. And that will be the segue to introduce our other speakers to describe what you are doing. At Mount Sinai right now, we have about 1,500 COVID-19 positive patients in our hospitals, including 251 ICU patients, most of whom are either fully ventilated or under intensive respiratory management. That is a lot of ICU patients. We have another 100 and some odd patients who are under investigation. But to think of this number of 250 ICU patients requiring the most intensive care, this has required a complete response from the health system. Dr. Rupa Kohli Seth is leading the Institute for Critical Care Medicine. And together with nursing staff and other attendings, she has mounted what can only be described as a military-style response. People's true colors come out in times of crisis, and Rupa has shown herself to be one of the great leaders of our time. And I'm sure that we all respect, I deeply respect what she's doing, and I'm sure it will be recognized as time passes. Here you can see how the disease is racing through our health system. And as you can see from these, we are still on the upswing of our crisis with so many patients in our hospitals. The hospitals we have are not enough to deal with the crisis. And as you may have read, we're partnering. This is just right across the street from where we are right now. As I drove in this morning, I saw the tents in full function. We have an 80-bed unit right now helping to decant some of our COVID patients from our sister hospitals. There's a command center. We're desperately reaching out to our partners to get PPE. China has been a real friend in donating, and we have received significant support from China in getting PPE into our health system. And many donors are reaching out directly to the institution and to doctors within our own department. Healthcare continues in our system, and we're now up to 2,000 video visits per day in the health system. Most of these are the things we would normally see in an office, which can't be done now. And so we're now up to 2,000 video visits per day, and this is accelerating. We're trying to stay on the cutting edge. We are now already giving what is called convalescent plasma to patients, to critically ill patients. We've developed an antibody test, and that is being used on employees already, although we're ramping up to scale as we speak. In our own department, we have already a very strong neurointensive care division with 9 faculty led by Neha Dengayich. Neha is not only leading our charge throughout the health system, but she's also the director of our Neuro Emergencies Management and Transfers program, and her leadership has been nothing short of spectacular. Our team of dedicated intensivists is led by Cappy Lay, Alexandra Reynolds, Caitlin Riley, and John Liang, in addition to Neha. And each one of these is deeply embedded in the front lines with heavy exposure to the highest risk and the exhausting schedules of taking care of our patients, as well as these other 3 attendings that I show you here. We were fortunate enough to have a brand new neurointensive care unit built a couple of years ago and just opening last year. This is an 18-bed unit, each with a closed negative pressure room. Unfortunately, the patients have piled up, and so we've now converted a number of these into 2 patient rooms, putting 2 patients into a negative pressure room behind closed doors. The issue of how to separate the COVID intensive rooms from the other areas where medical care is delivered is something that the Italians and Chinese have really helped us understand, and we are still working on it. This is an example of some of the measures that are being taken to avoid unnecessary movement in and out of the negative pressure room where a patient is, to set up the IV outside. We don't have anterooms. An anteroom would be even better, but our procedure for donning and doffing of PPE for people who are outside the room and go in and then come out again is rapidly evolving. The patients are incredibly sick, and you can imagine the burden of rounding on 36 patients, which would be our 18-bed unit with 2 patients in each unit. Right now, I believe the census was up to 28. This is an exhausting task, and although each patient is different, there are so many similarities that we're beginning to learn the patterns of what is the progression of disease, what sort of ventilator settings and ARDS management parameters we need to investigate and to manage. And here you can see one of the ways we're doing this by patient to pick out some key items and to report on these during morning sign-out. We've learned from our colleagues that proning is an important way to improve oxygenation in the sickest patients. And here you can see our team preparing to prone a patient. And you can see the exposure that our team is getting with these patients and the dedication of our team in doing so. It's not going unrecognized. There's been an outpouring of support from our community, with local restaurants donating food and a great recognition of what is happening. And this is important in this time of deep devotion and stress. Within the department, we are now approaching 100% redeployment of our 37 faculty. I will be doing my first shift in the COVID unit tomorrow morning, and we're working out the final schedule so that all of our attending faculty will be devoted a large percentage of our time either to direct management of COVID patients without neurosurgery diagnoses, or to redeploy ourselves in ways that allow us to care for neurosurgical diagnoses while our resources are being used to take care of COVID patients. Within our department, our neurosurgery census has dropped because we're only doing emergencies. We used to have at Mount Sinai, a month ago, we had 70 patients on our inpatient service just at one hospital. Our average daily census now is down to approximately 30 patients at 2 of our sites, at Mount Sinai Hospital and Mount Sinai West / Mount Sinai Morningside. We're continuing to do 2 to 4 cases per day at Mount Sinai Hospital. And I'll show you what sort of cases we're doing. I want to leave enough time to not be too late. One of the front lines are our advanced practice providers, our physician's assistants, nurse practitioners. At Mount Sinai Hospital, we've deployed almost all of them. And throughout the health system, we've deployed approximately 50 of our APPs and PAs. I wanted to recognize Leslie Schlachter, who was our chief PA, who's nothing short of miracle worker in mobilizing forces across 3 hospitals. Everyone already knows that she's an amazing human being, but she's rising to the task like I've never seen before. Here you can see what happened yesterday when she secured, through the generous donation of Tim Scanlon, a Lucas automated chest compression device that she brought in to our unit. Our entire residency has been turned over to the care of either COVID patients or to redeploying for resources. as our administrative and research team. We're only doing emergency cases, so a case like this that presents with mild progression, we're not doing that now. We're going to follow this patient. A case like this that has also shown progression, we're not doing this now. It's just going to wait. If things get a lot worse, we can always operate, but certainly this is not the way to focus our efforts. And even patients with significant symptoms of brainstem compression, we can't do this sort of case right now.
I think you're frozen there.
I am. Can you hear me?
Want to continue audio?
Can people hear me?
Yes.
Yeah. I definitely have a complete computer freeze here. Sorry about that. That's a complete computer freeze. I have no mouse, no nothing. So I was just getting ready to introduce our guests. So I think maybe the best thing would be for Chris Kellner to take over as host. And to continue. Otherwise, there'll be no visual for the meeting. And in the meantime, I will restart.
Okay.
Let me know when you've taken over as host, please.
Don't see that option.
If you can still hear me,
Yeah, we can still hear you. Yeah.
there's a massive technical glitch here. I think I'm going to have to restart my computer and rejoin the meeting.
Okay.
All right. So that's the only way out of this that I can see, unless I can join from my phone.
I'm also not able to control who is muted and who is not. So I'm not able to unmute or permit anybody else to talk.
So, a lot of participants, more than 200.
Oh, there we go. So, Dr. Schaller, why don't you begin now?
Hello, why don't you go ahead and give your presentation?
Yeah, maybe that would be an option. Huh? What do you think, Chris? Or what
Yes,
is it up?
let's do that.
Yeah. Okay. Like this, we will keep going. Okay. Let me share my screen. Jack. And move to the presentation. Can you see that, Chris?
No, I only see your video now.
Oh, this is ridiculous. Okay. Battery screen should be completely okay. Jack. This one, Jack. Sharing the screen.
Now you've got me on there.
You don't see my.
I just see, we can see your screen, but I'm the one on there.
Okay. Okay. New share. Okay. So. Anti-quality, Dominican should be okay. New share.
And then pull up the PowerPoint in the background.
The PowerPoint, you cannot see anything.
If you put the PowerPoint in the foreground, then
that's
we'll be
what
able to see it.
Yeah. It's in the foreground now.
Okay.
Okay.
Can you see it?
You have to share.
I shared it. And
We still see your video.
it's not so attractive. Okay, again. It says I'm completely sharing. So what else to do? Come application. Should be. Now?
Yes, perfect. Now can you make that full screen? There you go. Perfect.
Now I'll full screen. Okay, so hello everybody, without seeing you. May I introduce myself. My name is Karl Schaller. I happen to be the chairman of neurosurgery and of the clinical neuroscience department in Geneva. And this is a presentation which I did together, in fact, prepared together with Peter Wajkowski in Berlin. Peter, are you still there?
I'm still here.
Okay, very good. So we happened to meet last week, and we prepared for this session of today. And Johan, who should also be part of the EANS team of our European network of neurosurgeons. And are you still on, Johan? Johan? No, it's not. Okay.
Yes,
so
I am, but muted. So go ahead.
Okay. So just to give you a brief outline of what's happening currently in Europe, which is quite heterogeneous, and some of these things which have happened to us may obviously just occur to you for the time being. On the picture in the middle, you see the pangolin, one of the possible vectors of this virus. So to give you an overview of, because I presume there's many American neurosurgeons in the audience. So when we are talking about European neurosurgery, this is very, very heterogeneous. And the EANS is sort of the association of all these various national societies. And there's now a total of 40 membership societies from the far west coast, from our side, in Portugal, Spain, including Vladivostok, the eastern part of Russia, Scandinavia, Iceland, but also some countries of the Middle East. However, the situation is very, very heterogeneous. And now, meanwhile, due to the COVID-19 disease, there has been a consecutive shutdown endorsed by all of European countries, including Russia, as of Monday this week. So we are a community, of course, we are well connected because many of us, we are very good friends and we are monitoring very closely what's happening. And whenever one of us has a problem, we talk to each other, but our website forum is equally connecting us, and we have now a new website. And when you just push the button in the center, then you may connect with a website forum, which includes also guidelines and others. So, however, this COVID crisis has a big impact on our community, without doubt. And we have sections, as you do have as well, them in America, AANS, CNS, section of peripheral neurosurgery, whatsoever, and all these sections are activated. The section heads are sending surveys on how to practice neurosurgery in these days, what needs to be taken care of, and on and on. And there's one issue concerns the neurosurgical activity during this crisis, and Peter has done a big work on it last week on behalf of the German. Peter, maybe you can explain what's the BDNC and the DGNC and what you have done for the guidelines.
Oh, these are basically the two societies. The BDNC is more representing classically those that are in private practice, and the DGNC is more the academic arm of German neurosurgical societies. And as you will allude further on, we are struggling what we are still allowed to operate, how we can help our patients that still need surgeries. And we are all feeling depressed or not so comfortable that we should only do the very super urgent things. And we still believe our patients need our help. And therefore, this is a position paper where we tried to define what surgeries should be done. This was also done together with Bernhard Meyer and many other colleagues that you know. And we have defined, I would say we found a good midway or a good compromise, which procedures should be done and which should be postponed.
And Marike Brückmann from Utrecht and other partners from EANS have also worked on similar guidelines, and in fact is sort of quite a merge now of our European style guidelines, which may be looked at on our website. And what we define is of course, emergent case versus an entirely elective patient. Okay, this is serving as a platform, and for example, the Skullbase, the group, they have submitted, informed everyone that there's a high risk for the transmission of COVID during the transfer-nodal approaches, and this is where the EANS is in fact communicating or diffusing the knowledge of what's going on for all over Europe, and not only for the national societies. So some problems which we encountered, what we discussed in Germany already last week when I visited Peter, is that the public opinion is very much influenced by the expert opinions, and public gets easily hysterical, of course, and notably if the experts have diverging opinions. So currently, one of the drivers of the current political so the political advisor directly of Angie Merkel is Christian Drosten, who is a colleague, high-profile virologist, is a colleague of Peter at the Charité in Berlin, and he has already proposed a total lockdown of the public life early in March. Others, like the most genius French virologist, more than 3,000 papers in the PubMed. Well, only a week ago, he said that 287-plus-year-olds have died. They will have died last year as well, and he proposes chloroquine as a solution. The Israeli Nobel laureate, 1 week ago, he stated, or 10 days ago, that the coronavirus spread is slowing already, and we may almost cool down. So, and we may as well go back to John Garfield, one of the leading European neurosurgeons, who already 20 years ago stated that be a neurosurgeon is cooler than a neurologist, especially after the third gin and tonic, which contains, of course, a lot of chloroquine and goes with the opinion of Didier Raoult. However, this is very anecdotal, and we are facing real problems. There's also a lack of leadership, or there's such a diversity of opinions, at least in the beginning of the year. It was quite obvious when European leaders could not arrive at an agreement as to how to handle this situation. Boris Johnson is just one example for that. Okay, 3 weeks ago, I said, okay, wash your hands and business as usual. Then he was kissing his friends from all over the world, and it was on video. And however, a few weeks later, then he stated already that many lives will be sadly lost. And now there's a total lockdown in England as well in action. So what's missing for us across Europe is a common line of understanding of the situation, and to explain it in a proper manner and communicate it to the public, which of course merits information from the experts, and ideally in an understandable way, and ideally as coherent as possible, so as to not to cause panicking. Let me quickly embark on the situation on Switzerland in particular, and then I will show you some slides of what's happening in Europe currently. Switzerland is a very small country. France is here on the left for those who have never seen it in the map for the whole. Germany is the north, Austria in the east, and there's Italy towards the south, and France. So in Switzerland, there's 5 university hospitals: Geneva, Lausanne, Bern, Zurich, and Basel, and 3 big hospitals, but municipal hospitals, one in Aarau, one in St. Gallen in the east, and one in the very south, the Ticino, next to Italy, in Lugano. Here it doesn't mean there's no action here, but there's only mountains, so it doesn't make sense to have big hospitals there. And this is the European map. Switzerland would be here now, and the yellow stars reflect some important points of or hotspots of current corona outbreak or treatment. And of course, you are all aware, I think last week you had spoken with, I think you had Marco Fontanella, and he explained you the situation in Lombardy in the north of Italy, and Bergamo in particular, where the situation looked really catastrophic. And when I look at the photos, which I have seen today from Josh and what we've seen in the news about New York, it looks pretty much the same. There's a few hotspots, and we also currently are hospitalizing a lot of corona patients, as are our friends in Marseille and our colleagues in the northeast of France, where they are also really suffering. A few hotspots for outbreaks were as well. There's other. We had notably in Tyrol in Austria, a ski station named Ischgl, where people would still have huge parties during the outbreak, and then afterwards a lot of these people, before they could be quarantined, they returned to their hometowns, home countries, and became sort of super vectors for this disease. What is very interesting when you look at the hotspots here, or the yellow stars, where there's a lot of action and virus outbreak spots, in fact, however, not far around, there's almost nothing going on. We talked to our friends in Munich. They have close to 0 patients on the ICU, corona patients. Same holds true for Freiburg or for Bern, which is only 1 hour from me. This is very, very, very bizarre. And when we look at the outbreaks or potential spreader and starting points for this, in fact, mess which is happening currently, and there were several probably key events which ignited the whole spread, the spread of the virus. One was a huge football game in Bergamo between Valencia and Bergamo, end of February. Then there was a huge sort of feminist protestation manifestation in Paris, even in the second week of March still, which was not stopped. There was a huge football match, 60,000 attendance from Spain, of course, Atletico Madrid against Liverpool and Anfield Road. And then, of course, these bunga bunga parties still continue to go on until mid-March in Tyrol, in Austria, in the ski resorts. Whereas last week, when I visited Peter, this was on arrival on Sunday afternoon, it was like completely deserted in the heart of the biggest town of Europe. So cultural issues may play a role, and some particular events. And then there's something else which, of course, was not really communicated publicly, or not to everyone, I think, that in northern Italy, this is exactly where our friends are really suffering from this outbreak. Bergamo, not only in Prato, next to Florence, there is an estimated more than 100,000 illegal Chinese workers who are working in approximately 6,000 illegal small businesses, and who are glued together, living together, sometimes in very small rooms, and who had continued an ongoing exchange with their home country. And most of them came from the Hubei and Wuhan region until the end of February. So all these things, these factors, may play a role. Some are related to cultural behavior, others to economic issues, and how our society is currently functioning. What is really interesting is, of course, there's huge differences in Europe in terms of ICU beds per capita. You may have seen that in England, for example, a population of almost 70 million, they have less than 4,000 respirators. This is a scandal because they starved, they deprived the NHS of all means, financial means. Then there may be centralized hospitals, and their staff, as in Bergamo, who then became sort of super spreaders and vectors for the disease. And the healthcare systems in Europe are quite variable. There's some social Darwinistic models, like in UK, for example, and then there's some all-inclusive care systems, such as in DACH countries, because it's Germany, Austria, and Switzerland. What to make of the numbers? The daily numbers, what we see here, it was from the Financial Times, a report of a few days ago. Of course, we see all the lines going up exponentially straight and whatsoever. This, by the way, is Italy. Countries like France, Spain, UK, US are surpassing China, the Chinese curve already. However, this does not reflect the true infection rate, of course, because in some countries, more tests are performed than in others. Germany will ramp up to 1 million tests per week, this, as far as I understand. And in Italy, for example, they are still around 5 to 10 tests per 10,000 people. When you look at the number of staffed ICU beds per country, here you have all Europe, and you see For example, Portugal, they have 4 beds per 100,000 people only, and in Germany, there's about 30 ICU beds fully staffed per 100,000 of population. So there's huge difference across all Europe. And of course, Europe has to move and to collaborate in such moments of crisis, because these countries with such little number of low number of ICU beds will suffer the most, because people have to there must be a triage and must be decided by doctors who will have access to the ICU beds, and the ICUs will be totally crowded. For example, like your ICU, where you double the number of patients from 18 to 36. This is, of course, then getting very messy, and it increases the likelihood of virus spread, notably amongst the collaborators. Virus will be dead once the patients have left the hospital, but we will carry this on. So this has a huge impact on hospital capacity in Europe. And if you look at the number of coronavirus cases per critical care bed in each country, and for example, Italy, Spain, it's enormous. It's 8 or 10 patients per bed, whereas in Germany, it's like 1 to 1 only so far. It's also one of the reasons why some patients from France and Italy could be transferred to Germany. And the report from Bergamo, which was published last week or 2 weeks ago by the Bergamo group, they were quite clear about the fact that in the end, it's the hospitals where you centralize these patients, they become the main source of transmission to uninfected patients and people. We ourselves, the staff, we become carrier of this virus, and we spread it around. And especially if the ICUs and hospitals are totally crowded, and then the people, they change their PPE and whatever, however, if they work, they are tired, then in the end, this becomes like real super spreader bombs. Situation in Geneva is a bit tense, because Geneva, this is Switzerland. We are in the smallest, in the last appendix of Switzerland. In fact, there's a lake, and all around is sort of is France. We are a city state with only one huge university hospital and a lot of private clinics for many shishi surgeries, of course. But the university hospital has, of course, a big number of staff, and huge surface and ICU capacity. So our university hospital, with all, like you have, all high-end equipment, it was converted to some sort of a COVID lazaret. And following the first patient 0, which happened to be one of mine, unfortunately, who had this pneumonia in February, now we have converted the whole hospital to very COVID-oriented, and with the 110 ICU beds already ready, and we could create another 60 or 70. And we cooperate now with private hospitals for elective surgery. So we are doing elective spine surgery in private hospitals, and the orthopedic surgeons, thyroid surgeons, they work in private hospitals, but the university hospital will be totally contaminated and filled with corona patients. Of course, you have daily crisis meetings, reportings, Zoom meetings, and whatsoever. Our elective surgeries are down for all surgical departments to 20% since 2 weeks. Our interns are obliged to rotate for the ICU, such as yours, and help the anesthesiologists and the critical care specialists in the care of these patients. And these are the numbers of yesterday evening. We had 398 patients in our building, COVID positive. Out of these were 67 intubated and ventilated. More than 30 patients have died so far. However, very few on the ICU. Most of these people tend to die further down the line on the normal wards and not on the ICU. The rate of ECMO for the time being is 10%. So out of 70 intubated patients, 10 are on the ECMO currently. We had 2 sick children. One was waiting for a liver transplant, but both kids did very well, and they did not need intubation. However, if I look at my budget, this is a Department of Clinical Neurosciences. Since the mess started, since 2 weeks ago, we have an income loss as compared to the year before of 70%, because we see lesser patients, and the video consultation doesn't compensate for that. And neuroradiology, for example, they have shut down already 4 weeks ago, so I don't even have access to proper imaging anymore in clinical neurosciences. Then when I visited Peter and when you invited me, Josh, to assist these grand rounds, we sent out a survey this Monday to 27 of our close European friends who are all program directors, and all of them responded within 24 hours. It was very impressive. So we have from Barcelona, Marseille, Edinburgh to Moscow, Cyprus, Thessaloniki, Sofia, Zagreb, and here Germany, Benelux, Utrecht, Leuven, where Johan is working, and of course Berlin. So we had sent out a questionnaire, and we asked them if they had to reduce the surgery program, to what extent, for how many weeks, how many ICU beds in their hospital are ready to accommodate corona patients, how many they had on Monday evening, how they consider the impact of the whole mess on their practice, and if they believe that the whole hype is going too far, or whether it's justified to shut down so much. It was very interesting. So all of them had to reduce, all. The percentage ranged from 30 to 100%, but the median was 80%, like in my hospital, for example. The median since 2 weeks, and how many ICU beds ready in total, depending on the size of the university hospital, from 34 up to 300. 300 is a Charité in Berlin. This is Peter's hospital. However, very interesting, and this is something we will discuss later probably, and I already showed you on the European map before. The number of patients in the ICU is totally diverging. Out of the 27 centers, 10 centers had only 0 to 8 patients, and the median is 24 patients. Some other have already 80, more than 80 patients. So the ICU is completely flooded, like ours, with corona patients. And the numbers, of course, include those patients already who have been transferred, for example, from Italy or Spain or France to Austria or Germany or Switzerland or Luxembourg. So we're helping each other. However, there's a huge discrepancy between the different centers, and it's not entirely clear if they are just later behind in the overall evolution of the crisis, or if they have just better healthcare, better access, or whatever. This needs to be discussed. Then the impact was considered severe by 90% of the responders to our questionnaire, and the whole hype is going too far. Yes, 20 of us, we believe that this impact, what we are currently doing as neurosurgeons in the context of this crisis, this is going too far, and we are putting in danger, endangering, and jeopardizing our regular care, and patients may be left behind. And Peter will tell more about that later. 6 of us, mainly those like Marseille or Barcelona, where they are really suffering from this misery the most, and Northern Italy say no, because they see how severe the situation is escalating, such as in your own hospital in New York, what we have seen. 2 cities have a different approach. For example, Moscow and Zagreb, they have built or dedicated particular hospitals to hospitalize these corona patients, and they have sort of reduced the elective surgery because the doctors may have to help in the COVID hospitals. However, their main university hospital-based core hospitals, they stay clean from these patients. And this is leading us to the dilemma, and Peter would will talk to you about that. Peter? Peter?
Can I just make a comment?
Oh, yeah.
Hey, thank you very much. That's incredibly interesting, particularly the diversity of response. Of course, we're running a little bit late, and in part to me, in part to technical difficulties. I would very much like to get a chance for the audience who have been submitting questions to give them a chance. So Peter, looking forward to your comments. If we can try to keep them as quick as possible, then we have questions for you and to us from the audience that I'd like to get a chance. So welcome. And by the way, before we do that, I just need to show you what I had planned to show you. That we're hearing from three of the most important neurosurgeons in Europe. I don't know if we had a chance to introduce Carl, but he's professor and chair at Geneva University Medical Center, director of their amazing Center of Neurosciences. He's been a personal friend for many years, and many of you know him, but some on the US side of this meeting may not know him as well as we should. Likewise, Peter is becoming a friend of mine as well, and he is leading one of Europe's big neurosurgery centers. He just sent a student, Leah, to us, and we got a bit of a sense of how well their students are trained, and Peter is a clear international leader in neurosurgery, so we look forward to your comments. And Johannes van Loon, who's EANS secretary and professor and chair at in Belgium. So with that, I will turn it back to you, Peter, and look forward to hear your comments now.
Oh, thank you, Josh. First of all, thanks for the invitation. And I think that Carlo has very nicely summarized his thoughts and the thoughts of friends that we are in continuous exchange on what's going on in Europe and in Germany. And if we go back to the presentation, is that possible?
Oh yeah, I thought I hear him back, but okay. Wait.
Can you share your screen again, Carl?
Have to again share, yeah. Check. Now.
Yeah.
Perfect.
Okay, I will.
I think we have to appreciate that we in Germany in particular, but in many areas in Europe, are still in the comfortable situation of discussing whether we should continue to operate or not. I can acknowledge that with 250 ICU beds taken and all the staff moved to the ICU, I think that does not leave much room for other surgeries. But certainly one can discuss whether all these patients have to be at the university medical centers, and maybe this will have an impact on how the health system will be restructured in the future. The dilemma that we saw together with Bernhard Meyer when we were discussing it with the two societies is it really justified to lock down neurosurgery? And you have seen the response that even in the areas that are mostly affected in Italy and Spain,
Like Zoom is overpowered today.
I think we lost his video, his audio.
Peter, we lost your audio there.
Peter is gone.
Oh, now cut out.
I think his computer just went on the blink.
Okay. Well, the discussion is, of course, we are fearing that behind the big tsunami of this corona crisis, which is passing through all Europe, that we are creating a silent catastrophe behind. Because what we observed across all countries in Europe is that even the emergency patient, the number of patients decreased. Even the lesser strokes, lesser hemorrhage, and people, either they are afraid to come to the hospital because they believe it's corona ridden, or they die at home, they start committing suicide. We don't know. So we are leaving a huge number of patients behind. We are creating collateral damage in the system. And this is why, for example, in my opinion, in my hospital, we should have, now we are converted the whole university platform, the corona treatment. And we could have, for example, my hybrid rooms and interventional MRI ORs, they are now rooms to keep the mouth mask and PPE. I can't do proper surgery of the 21st century anymore.
So, I think this is a good moment to start to open
There
it
is,
up
there are,
to
can you hear
discussion.
me?
Professor
Yeah,
is zurück.
I'm sorry, obviously the internet is a little bit unstable, but I would like to add to Carlo that there is a recent estimation from cardiology and from neurology that patients coming to the hospitals, and this is not only the major hospitals, but this is every hospital, the incidence of patients reporting to the ICU with heart attacks or brain stroke has gone down by 62.
Okay, I think we have, we're having a little bit of a problem with Peter's computer.
So you may
I think what we will do is now open this up to some questions. And I've been getting some questions from outside. And one of the ones that keeps coming up again is, can we please discuss our policy with neurosurgery patients without overt COVID symptoms? How do we assess patients who are unconscious with trauma? Do we treat them as possible COVID patients? And how do we protect ourselves from the risk of contracting COVID when you're not on a COVID ward? I think for this, I'm going to ask Dr. Mako, who is our vice chair and director of the residency program.
You have to identify him on the list and then make him a panelist, or give him permission to speak.
I'm trying to, but he's not. I don't see him there.
There's a search option at the top.
Yeah. No, I'm
Okay, I see. He's probably, maybe he's on his phone.
Eric Orman, are you there?
Yes, he's there.
All right, Eric. Eric is our chief resident and instructor in neurosurgery. How are the residents dealing with this question? The question is, when a non-COVID patient comes into the ICU or to the ward and they need treatment, how are we approaching that patient when we know there's a risk there?
Did you give him permission to speak, or pull him up as a panelist?
I said aloud. Yeah, he's
okay. Good.
Go ahead, Eric.
For the, I think one of the major changes that I'm seeing, especially for the neurosurgery residents, is very like a high degree of attentiveness to the non-neurologic kind of examination and symptoms. Knowing that a lot of these patients, are at risk for COVID, and the importance of identifying prior fevers, sick contacts, any kind of like respiratory symptoms. It's something that we're all, I think, very attentive to when seeing new consults and evaluating new patients. And then, if patients have concerning symptoms or concerning history in terms of like sick contacts, immediately incorporating that in our neurosurgical planning and management with regards to, swabbing them and thinking about bed management going forwards during the admission.
So in talking with our Italian and Chinese colleagues, this methodology has proven to be very unsafe. And that is because if you rely on history and symptoms, you're going to miss people who slip through the cracks. So, and this pertains a little bit to what Carlo was talking about. The movement is to create green zones where the patients that need neurosurgery and other treatments, cancer patients, for example, can be treated in a relatively safe environment that is free of the highest risk of COVID. It may not be possible to reduce that risk to zero. But to take the example of the interventional suite being used to store masks that Carlo just told us about, that is an extreme example of using an incredibly expensive and valuable resource that if we were able to divide up our resources a little bit better, we might be able to preserve that function. It may not be possible to do that by hospital. And so what we're exploring at Mount Sinai now is the creation of a green zone, even here near where I am right now, that would allow for the urgent neurosurgery cases in a relatively, and then their post-op care in a relatively COVID-free environment. Johannes, can you comment on what your concept of this is and how you'd like to approach that?
Yeah, thanks. Hello, everyone. What I see here in Belgium is that things are changing about every day, and it depends on the availability of testing, which was a problem in the beginning of the crisis 2 weeks ago. The availability of PPE, FFP2 masks, and so on, and we see that when these products become more and more available, you get allowed to test more, you get allowed to use safer PPEs more and more. So we're really adapting to what is happening day by day. What we do at the moment is for asymptomatic patients, we do a screening with a nose swab. And that is, I'm told, should be safe in a way that these patients may be already infected and may be spreading virus, but you will detect that with the swab. They're not allowed to be in the hospital after the swab was taken, and they're only allowed into the hospital when the swab turns out to be negative. So the PCR has to be negative before the patient, for an elective case, is allowed into the hospital. Every patient that has symptoms gets the same swab for PCR and gets a CT scan of the chest. So we believe that we are working at the margin and that we're pushing the margin a bit further. We're, as is said for certain centers in Switzerland and Germany, Peter Center definitely, we're on the safe side of having beds available. So we believe we're still coping. But as I said, we're changing our rules, and they're not really, the change is not really based on scientific things, rather depends a bit on the materials that are available or not in sufficient ways.
Thank you. Thank you. What about the concept of green zones? Chirag Gandhi, are you on the line? Not yet. Carl, can you comment on the concept of a green zone? How would that work in your hospital?
This discussion is taking off, but only slowly now. In the beginning, we had to move whole wards, and we had to create one ward for COVID patients and the other ward for sort of non-COVID patients, regular patients. But the current view of the hospital policy is as follows. We still believe we have an increasing number to deal with of these patients. And for the time being, for example, whatever is super high-tech medicine has to stay back. So I'm discussion, but I'm a bit of an enfant terrible, and I have to be careful not to pop out too much. Otherwise, I might be decapitated, because now is a this is the biggest time in the life of people who may always have dreamed to control the hospitals and to have such a crisis situation to evolve. And here they are doing a great job. These people are very sick, these patients, but at the same time, I cannot operate those who may need. Like your patient with a 53-year-old with a huge petroclival meningioma, I would have to send this patient to Bern, because Bern all is quiet. Because I cannot even provide a date for a surgery.
Right. It's a fascinating moment. The other thing that everyone has mentioned is the observation that the apparent irreducible emergencies are decreasing. Trauma, stroke, and so on. I think trauma is easy to understand, easier because people are staying inside, so they're not getting in trouble. Whether or not the stroke is really reducing remains to be seen. Our normal stroke volume is about, our endovascular volume is about 2,000 per year, and we're down now to about 2 per day. So that's a reduction of more than 50%. The other thing that Johannes mentioned that I think is incredibly interesting, and I'm going to call on Neha Dengaich to comment. Johannes mentioned the concept that they're learning very rapidly, and their techniques are evolving quickly as to who they choose to operate on, who and how they manage things. One of the things that we are learning, and I think Carl made mention of this, is that it's not so much the patient we're worried about; it's the physician who's most likely to be the carrier. And so, how to test, how to monitor, and how to use PPE for the physicians ends up being one of the most important aspects here. So I'm going to ask Neha Dengaich, who is the director of our critical care effort here, to comment on this. Neha, I'm trying to unmute you here. Chris, maybe you took over. Can you unmute?
Thank you. Can you hear me?
Yes.
Great. So I think this is a very important question. And if we think about how there's this widespread community transmission of COVID and a fair number of asymptomatic carriers that we're not going to be able to identify if we're not testing appropriately, the most important thing that we have seen in the United States overall has been a lack of mass testing and testing asymptomatic carriers, unlike the South Korean approach where a lot of patients were being tested. So I think whether they were symptomatic or not symptomatic, perhaps it's a very important time for us to think again about how we're deploying our testing measures, how we're using some newer tests that are available, our antibody testing strategies that just became available last week. And should we be screening our patients just like we screen patients for MRSA or staph aureus? We're doing swabs for MDROs or multi-drug resistant organisms when patients come from certain high-risk categories. Right now, the entire community is a high-risk category. So irrespective of what our patients are coming in with, I do feel that it's important to start testing them more liberally. And perhaps if we don't have enough tests to go around, then at least doing random sampling to be able to understand what is the proportion of this problem to safeguard our healthcare teams, health frontline providers who are going to take care of these patients, irrespective of whether they are COVID positive or not COVID positive.
Thank you. Well, I think we're gonna transition now to the next three guests that we have invited, Dr. Fawaz Al-Mufti, Dr. Shirag Gandhi, and Neha. Let me just share my screen with you so you'll get a sense of this. And before I do that, I wanted to thank our guests from Europe, Carl, Peter, Johannes. I apologize for some of the technical glitches here, but this is the first time we've done it, and I'm hoping that people found it useful. For me, it was very interesting to hear what is going on in Europe, how well you're communicating, and the incredible diversity of experience, no less diverse than what we're seeing between our East Coast and Central United States. You have the same level of diversity. It's reassuring to see the quality of leadership that you have and the devotion that you are giving to this problem. So thank you very much for joining us. I hope you'll stay with us as we focus a little more now on New York.
Thank you. Bye. And all the best to New York and Mount Sinai.
Thank you. Thank you, Johannes. And thank you, Peter and Carl. Fawaz Al-Mufti from Valhalla, Associate Professor in the Departments of Neurology and Neurosurgery, is going to speak with us. As well, Neha, I introduced, and Saad Bhatti from Elmhurst, who has been leading the charge for us there. So I'll turn it over first to Chris. Should we start with Fawaz?
Neha, I believe you have an order. You're muted there. Yeah, there you go.
I think we're going to start with Saad first. I'll go next, and Fawaz will be going last. Thank you.
Welcome.
Hi, good
Saad.
morning, everybody. Hi, thank you. Thank you for the invitation. Is everybody able to hear me?
Yes.
That's more important than seeing me. Okay. I mean, thank you to all the people. I joined in maybe 10 minutes ago, and I was able to get some perspective of how things are. I'll start by saying that from what we have seen so far at Elmhurst is that it's safe to assume. I wouldn't even use the word assume. Please consider everybody, every patient that you see as having COVID. So for any doctor or any healthcare provider who is assessing any patient, please do not second guess that could this person have COVID, right? So please take appropriate personal precautions, which involves the use of appropriate, properly fitting masks and a face shield, because the last thing you want to do is to expose yourself and not be available to take care of patients because of the need to go into quarantine. Over here at Elmhurst, I have a perspective more from an ICU point of view. We started seeing an influx of patients coming in with respiratory failure from March 9th. March 9th, the week of March 9th, generally our medical ICU has 8 beds. All of those 8 beds were taken up by patients with ARDS. And at that time, the turnaround time was 5 days, and majority of them were thought to be presumed COVID. Some had COPD exacerbation, but others were coming in from various nursing homes and long-term care facilities, and some younger people as well, with symptoms suggestive of COVID. Over the weekend, we have an old ICU, which was being used as a holding area. So that had to be fashioned back into a full-fledged ICU. And those 8 beds were also taken up. So we had 16 of our medical ICU beds taken up by the COVID ARDS patients. And within the middle of next week, which was March 18th, we had 7 patients in our surgical ICU out of 12, which were taken over by the COVID ARDS patients, as well as all of our 8 beds in CCU. They were taken over by patients in respiratory failure who had COVID. And this trend since then has continued. We have a medical step-down unit, which has 32 beds, which is also taken up by patients who are requiring mechanical ventilation. And we have, as of today, 60 patients spread all across the hospital in ICUs, as well as in our medical step-down unit with COVID ARDS. The sobering fact about all of this is that so far, we have only been able to successfully extubate 2 patients. The rest of them are requiring long-term care in resource-intense areas of the hospital. We have also been able to look at our mortality trends. So for those who do not know, or may not know, ours is a 550-bed community-based hospital. On average, going from January 2019 up until February 2020, we used to have between 55 to 60 mortalities. So it comes out to average of 58 patients expiring in hospital across all age groups from various type of illnesses. Ever since March 20th, we have had 106 expiries. So it comes out to an average of 10 patients passing away every day. And when we look at the age breakup of the patients who have expired here, we have of these 110 patients, we had 14 deaths in age less than 50 and 14 deaths in age less than 60. But for the age group higher than 60 to 70 and 70 to 80 and 80 and above, we had 22, 25, and 31 deaths. So it gives us an idea that for patients so far here at Elmhurst who are older than 60, from the trends that we have seen in the last 15 days, their chances of survival are minimal. On average, patients are staying on mechanical ventilation, those who do not survive, between 3 to 5 days. And then they're going into multi-organ failure, requiring vasoactive support, use of pressor agents, and then going into renal failure, not stable enough. And plus, we do not have resources to offer renal replacement therapy to everyone because of the lack of staff and machinery. And they are succumbing to this illness. And as far as general medical wards are concerned, we have 5 general medical wards where people get admitted, each with 34 bed capacities. 4 of them are now full of patients who are confirmed positive. And our influx of patients needing ICU care is coming in from those who are on the wards, as well as those who are presenting in ER and are deteriorating within few hours to the point of needing either non-invasive mechanical ventilation or to the point of needing intubation and then a ventilator. So these are pretty humbling circumstances. And it's, as I said, the age range of patients that we are seeing is all across. We have started seeing patients in their mid-30s, in their 40s, and especially those who are older than 50s who have been.
Saad, can I ask you a question? Can I ask you a question, Saad? I'd like you to go back over a little bit again. You mentioned the number of mortalities, but you did not give us a mortality rate. And I would like you to compare that as well to the incidence rate of infection by age decile. So you mentioned a high mortality figure for people over 60. What is the infection incidence by decile?
That I'll have to look into because I don't have complete information about that. I don't have a denominator. I agree with you. It's possible that because of my unique perspective of working in an ICU, that I do not have complete information as to number of patients who are coming to hospital and getting discharged. Once I have that information, I'll email it to Ernest or somebody so that the group gets an idea about the denominator and the incidence. Absolutely, I agree. These are very valid.
You know what we saw, and Chris, can you make Jay a panelist? Because I don't see him as a panelist, but
Give me a second.
Jay and I were looking at the data out of China and Italy, and for incidence numbers, what they are publishing, and it's pretty consistent, is that the risk of being a COVID patient in your 60s, 60 and above, is 10 times greater than the risk in your 40s, and that there is a risk of infection in your 50s that is 3 times greater than your 40s. So it was about 0.7% of infected patients were in their 40s, about 2 or 2.1% in your 50s, and about 7 to 10% above 60. So that gives you a 3-fold and a 10-fold increase of the risk of contracting, or at least the incidence of that disease in those patient groups. Jay, do you want to comment on that? I see that we have access to you now. I'm trying to unmute you. Chris, I think you can do that. Thank you.
He's unmuted.
I mean, these are real. So I spent yesterday going through what literature we have out of Spain, China, Italy, in regards to comorbidities, age, and other things. And there's enough data to be pretty relatively confident on a lot of these differences. What's encouraging is, obviously, for the very young, it seems to be extremely I don't know if protective is the right word, but not virulent, which is very nice. So that's a plus.
Do you agree to those numbers that I mentioned?
Yeah, I have, and let me just pull up. I have in front of me the data from all of those from a figure, from a graph. Sorry, everyone, I'm just getting access to it. But essentially, yeah, you go from 50 to 60, 50 to 59. It's about a 1% case fatality rate. To 60 to 69, it goes up to 3.5%, and both in China and Italy. And 70, 79, it goes up to, in China only 8%, but in Italy almost 13%. So it really jumps. And if you're over 80, it goes up to 15 and 20%. Interestingly, it's hard with some of these because cardiovascular disease, it's hard to know exactly what they're considering. But significant cardiovascular disease carries about a 10% case fatality rate. That's probably an interaction effect with age. Interestingly, diabetes has a big jump of about 7% case fatality rate. And some other random ones, cancer, chronic respiratory disease, and others. So I'm actually putting together a little collection of some of this data to share with our faculty.
Good, thank you. Assad, what else did you have to tell us, or would you like us to move on to someone else?
I mean, I think as one of the presenters was mentioning that, I mean, this is something which is going to take its time, and we, for people in subspecialties as you, I think your resources should be utilized for the purpose they are built. I mean, it doesn't make much, I wouldn't say much sense, but I don't think it's the best use of resources for an area which is meant to take care of a particular type of disease process to be used for a general ARDS patient. I mean, if it is needed, then they may have to use it, but there are other places in hospital which can be utilized for that. I don't want to be too critical, but at our hospital, they have started using the PACU without making complete use of the medical step-down unit first, saturating that first, because the amount of time a person is going to stay on mechanical ventilation is going to be between 7 to 10 days. So it's not a one-time small surge that a person can think that it will be taken care of in a short period of time. So we have to look at it from a longer perspective and be able to provide care to patients. As you said, there are people coming in with strokes or other neurosurgical procedures that need to be taken care of. And we should do our level best to keep them safe from exposure to COVID. I mean, it's a brilliant idea to screen, if possible, not everybody, but at least the patients coming in. And if they are negative, there should be an area where everybody else who goes in is also negative, so as to say, so that they don't get something in the hospital which they didn't come in with.
Great, and thank you, Saad, for that perspective. A couple of points that you made that I'd like to just emphasize, and this gets back to Eric, how you are, Eric Oerman, and our neurosurgery residents who are at Mount Sinai. I think you have to consider that everyone is positive. I don't think it is going to be safe for you to use some algorithm of history, of symptoms, of family contacts. I think that's going to put you right in harm's way. So,
Dr. Benison,
yes.
In fact, I think a notice just went out from the institution where all patients, it is now considered endemic throughout the hospital, and all patient-facing interactions of any sort should be considered to be as if COVID positive.
Right. So I think this is a very important point. And the other thing that we are focusing on has been the patient. But what I'm hearing over and over again from my colleagues in Italy and China is that we're hyper aware of our contact with patients, but we co-localize with each other. And in the same way that it's endemic throughout the patient population, it also is in the physicians, many of whom are asymptomatic. So we have to exercise social distancing and PPE protection when we interact with each other in giving care.
For this is Jay again. For those people listening that are not sort of in the midst of this, there's some steps that we've taken over the last 2 days that I wish we had thought of taking 2 weeks ago. But in reviewing sort of the literature, the stuff out of China and what's been successful for the residents, we've now identified 2 additional office spaces where we've set up workstations so that many residency programs, at least ours, have all of the residents in a particularly one team room. But that creates too much opportunity for cross-contamination. So yesterday we activated 2 additional sites to make sure the residents are completely spread out and the teams are not crossing paths with each other. And today we are setting up a dirty room for them to don and doff their PPE. So when they come back to the office area, at least the outer layer, while not perfect, it can decrease the overall viral load and cross-contamination. They can carefully doff their PPE, and we're hopefully we'll be mounting a hand sanitizer, clean up before they leave that room to then go to do their more daily work, and computer access and other things.
Great.
Okay, along those same lines, one of the questions that's come up at our hospital is the way that all of us, or a lot of us, I'm certainly guilty of it, come in and out of the hospital with scrubs on, right? And what we're doing, what precautions we're taking to not carry this stuff home to our families. Have there been policies put in place at your hospital to deal with this?
Well, from the resident perspective, we've I just had a meeting this morning with them actually, and with the CV faculty yesterday on this issue. We're asking them to get 2 pairs of scrubs and to don 1 pair, put on their PPE, do their work for the day, keep the other pair in that dirty room so that they then change out of all of that, change into a clean pair, and then use that to go to a cleaner room where they can put on their street clothes before going home. But absolutely, staff should not be going in and out with the clothes with any materials that they wore in direct patient care areas to home. And what we've started, again, this is something I wish we had done 2 weeks ago. We've started a process of creating a secondary decompression of clothing and things, so that there's a dirty room and then you go back and then you put your street clothes on.
Neha, do you want to comment on this?
I think all these measures are very important, but thinking about, Dr. Berison, you mentioned the ante-room for a lot of the patient care areas. Unfortunately, we don't have that. In all the COVID ICUs, there are very few ICU rooms that actually have an ante-room or a warm zone where you can actually doff. So what we're doing right now to prevent cross-contamination as much as possible, we're doffing in the patient rooms, but leaving that face shield on and our N95s on. So that face shield is the only aspect of our PPE that's coming outside the room, and then we wipe it down with bleach because we're reusing these face shields and keeping that N95 mask on. For all the residents, I think it's a great idea to have those different rooms. That's very, very important for social distancing. We're trying to, even within our KCC9 COVID unit, where we have our fishbowl, where the team tends to spend a lot of time reviewing patients, etc. We're trying to minimize the total number of people in that room at a given point in time.
I want to make a comment on how to help each other. There's a very strong social mandate or social habit that makes people worried or embarrassed or afraid to speak up if they see something that looks difficult or like someone is contaminating. And people don't want to complain. They want to be seen as strong and not afraid. This is a very strong thing that that we all deal with. It comes on the leaders to point out these errors and flaws when we see them. And that could be a leader at any level. It could be the team leader in a group of 5 residents. It could be Neha and her team. It could be me. Could be any one of us who's here. You need to speak up and point out where the lack of technique, is there a name for that technique? You know, the donning and doffing? The good technique that is required to prevent the spread of the virus, we have to enforce that and encourage people to do it. If left to our own devices, it's human nature to congregate together, to get close to one another, and to not want to feel afraid or be seen as being afraid. It's very important to have a leader in every case that points these things out and also tries to find solutions when a problem is identified. I want to get back to the question that Chirag asked. So the concept here is we want to avoid virus getting out of the contaminated areas. And the concept of the circle around the contaminated area is one that is helpful to use, I think. We have multiple circles. So the worst area is a positive pressure room with a COVID positive patient. The next area would be a negative pressure room with a known COVID positive patient. The next area would be a general ward where you're not sure if people are COVID positive. The next area would be your office, if you have an office or an office where you work with your colleagues. The next area would be your car or whatever commuting you take. And the final circle would be your home. So I would urge people to consider every time they move from the higher zone, the higher level zone, into the next lower level zone, what are you doing to manage reduced contamination? I would think you should view your office as your home. If you have a main vestibule in your office, that should be viewed as an enter-room. But you should be doffing, taking off the materials and clothing, all your clothing, before you enter those areas that you consider clean. So it's just a helpful framework, but unless you are observing it fairly strictly, it won't work. Okay, who's next? We still have a few minutes left in this conference. Neha, who's next on your list?
So I was going to go next, but in the interest of time, should we have Fawaz go in? What do you think?
We're going until 9 o'clock today. We do.
Okay, good. Okay, thank you. Thank you, Chris. So I'm going to share my screen. Let me know if you can see my slides.
Not yet.
Not yet. Okay, let me see. Should work.
There we go.
Also, we have some Q&A to bring up too, so maybe after each speaker, we can take a minute or two.
It's taking a little bit of time to go into slide sharing mode, but I do not have any disclosures directly related to this presentation. My screen is currently frozen. I don't know if you can still see my slides.
We just see your first slide.
Okay.
I have your slide, so if you're frozen, oh, there you go. You're on now.
Okay, but it's not advancing. Okay, all right, let's see if that's going to work. All right, so the New Yorker cover from yesterday was very pertinent to how we're all handling this crisis situation. And whether it's at home, whether it's at work, a lot has changed for all of us, and we're trying to leverage technology everywhere that we can to provide the most compassionate care possible. I think with this collaboration, with this collaborative resilience, we're going to bounce back from this crisis. I have no doubt about that. And when I think about the positive things that are coming out of this COVID crisis, it's really bringing out the hero in each one of us at every possible level. The sheer collaboration that I have seen throughout our health system, that we're seeing globally, has been very inspiring. And when I think about how freely knowledge is being exchanged on social media, or how people across the globe are supporting each other, I haven't seen this kind of support before. So that's very, very encouraging. And I think this is going to take us through this crisis. Just a few words about PPE. My slide is frozen on the PPE slide right now, but thinking about all the aspects of PPE, there's infection prevention, materials management, occupational health, industrial hygiene. All of those aspects are needed to really, really make this work. So these are some slides from two major organizations in the United States that are responsible for ensuring that we have the right PPE. When we think about the hierarchy of controls when we're trying to take full control of a pandemic, PPE is at the bottom. It's the least effective type of control. What we really, all those other measures, whether it's elimination, substituting, engineering controls, administrative controls, they have a much greater impact. But PPE impacts us as we come down to direct patient contact. But everything that happens to that patient before they become a patient, before they come to us, is of paramount importance. So all the state level organizations, federal organizations, our CDC, all these other organizations that are responsible for coming up with occupational hazard prevention. These are very, very important in gaining control over the spread of a pandemic. Transmission-based precautions are part of what we all learn when we are taking care of patients in a hospital or an outpatient setting. Standard precautions are precautions that we're all used to taking: hand hygiene, making sure that we're engaging in hand hygiene before and after patient contact, not using the same devices in between patients, using disposable devices. So a lot of common sense that has been ingrained into all of us right from the times when we started taking care of our patients. Then some commonly used terminology: contact precaution, droplet precaution, airborne precaution. Think about your C. diff patient when you're wearing that contact gown and gloves, and before coming out of that, before entering the room, hand hygiene with Purell, but as you're coming out of the room, making sure that you wash your hands with soap and water. Droplet versus airborne. There might be some confusion in the audience amongst what is droplet precaution versus airborne precaution. So when we think about a droplet, it's essentially less than it's greater than or equal to 5 microns in size, and airborne particles are lesser than or equal to about 5 microns in size. So it's the size of the infectious material or body fluid that could contain infectious material that distinguishes between droplet and airborne, and for how long does that particles stay suspended in air is what guides whether we should be practicing droplet precautions or airborne precautions. You've probably heard about the evolution in how we're thinking about COVID-19 precautions. We think about droplet precautions in all scenarios as you're coming in contact with COVID patients, but those procedures that can lead to further aerosolization of viral particles, those are the kinds of procedures where an N95 was initially recommended. So what are N95 in addition to all the other precautions like gloves and gowns, face shield, goggles, bonnet, etc. Those aerosolizing procedures, just as a reminder to everybody, some of the most high-risk procedures include endotracheal intubation, bronchoscopies, chest PT, tracheostomies. those are very high-risk procedures. So making sure that you have your full PPE with an N95 mask on is very important. The CDC also released some guidance on alternatives to NEOSHA-approved N95 masks. On the left-hand side panel, you just see a snapshot of that. And why are we even talking about alternatives to N95? Because we're all very aware of the PPE shortage that that we're experiencing, just given that we're burning through our PPE at a much faster rate that we can replete it. More recently, the CDC and the WHO had a burn rate calculator on their website for how quickly you're going through your PPE. So how do we stay ahead of the curve? That's pretty much the message that I'd like to give you through this presentation. And there are lots of sources that are working on procuring more PPE. But to address some controversies about PPE in the United States versus some of the other parts of the world, the basic foundation of PPE, eye protection, whether you're using goggles or something else, a face shield, isolation gowns, face masks, and respirators. There's a difference between a face mask and a respirator. The surgical face mask you're all familiar with, respirator. The most commonly used and approved respirator is the N95 respirator in the United States. On the left-hand side of the screen, here's a snapshot of what the CDC approved PPE is for healthcare providers, and where again, there's a face shield, there's goggles, there's an N95 mask, there's a gown. They're recommending one pair of clean gloves. Most of us are using double gloves so as not to contaminate ourselves when we're doffing, and then using booties or shoe covers. This picture from Wuhan, several of us have seen these Tyvek bodysuits that several healthcare providers in different parts of the world have used. Whether it's really needed or not, that's something for us to, that's been an area of controversy. But from what we know from the CDC and WHO, these Tyvek suits are not currently part of at least the least possible standard of PPE that's being recommended. And one quick point about donning and doffing. Dr. Beresin already emphasized this. Thinking about having a doffing coach is very important, so as not to contaminate yourselves. Critical care resources, I do not need to belabor this point. We do have an acute shortage of ICU beds, but creating capacity by repurposing areas in the hospital for ensuring that we were able to take care of our critically ill patients has become important. Similarly, for expanding our teams, a tiered staffing model was proposed by the SCCM, and I'm sure several of you have already seen that. So who needs the ICU? When we think about those patients who have acute hypoxemic respiratory failure and require invasive mechanical ventilation, hypotensive patients or patients who are in shock, and we're going to see different types of shock in these patients. Distributive shock, mostly because of sepsis or septic shock, and cardiogenic shock, and combo shock because of viral myocarditis or demand ischemia for patients who have underlying heart failure already, and acute renal failure requiring renal replacement therapy. Just a quick snapshot of the ICU experience in these patients. So on the left-hand side of this panel, this is again from Wuhan, 107 patient experience. Of those, 17% required ICU admission, and they showed a trajectory. What were the differences in who died versus who was discharged? And when we think about this hyperimmune syndrome that these patients develop, it's those patients who go into multi-organ dysfunction with a hyperimmune response. They are at a higher risk of dying, and we've already discussed some of the high-risk characteristics, so I won't go over that. The paper that, this snapshot is from a paper that was just published yesterday. It's the Seattle experience, and they had about 50% mortality in their 24 patients. This is unpublished data out of Italy. About 1,300 patients, 99% of those patients, this is just critical care needs, 99% required some form of respiratory support, 88% with mechanical ventilation. And they did have about 1% patients requiring ECMO. Of those, 26% patients, or 405 out of 1,300, had died, but there were still several who were still in the hospital. So quick, I will go through this in the next 2 minutes. ARDS, bilateral fluffy shadows, your PaO2 by FiO2 ratio less than 300, and requiring at least a PEEP of 5, and having a non-cardiogenic cause for this kind of pulmonary edema, this interstitial edema, that we should all become very familiar with. This is a great review from Michael Mathey, who spent his life on doing ARDS research. So it was just published in Lancet a couple of days ago. So I'll just go over the SCCM guidelines. So a few things to keep in mind for all patients with, as you're managing patients with ARDS: low tidal volumes, empiric coverage with broad spectrum antibiotics, and targeting saturation, O2 saturation of only 90 to 96%. Using conservative fluid strategies, so we're to try to run these patients as dry as possible. And in terms of optimizing their sedation, something we are experiencing, propofol may not always be a good choice because these patients do have some baseline. They're coming in with some hypertriglyceridemia already. So sedation, paralysis, low tidal volumes, high PEEP, and maintaining low driving pressures. So those are some keys in managing patients with ARDS. Using early neuromuscular blockade, and ensuring that we're proning these patients early. So proning data comes from a well-designed randomized controlled clinical trial. These patients are responding really well to proning for about 12 to 16 hours, but prone these patients early. So who should you intubate? Before this guideline statement came out, we were not using non-invasive ventilation as much in these patients because of fear of aerosolization. So patients who are on high flow nasal cannula, there has been experience from Wuhan, it's still not been published, but showing that patients, we can prevent intubations in these patients by using high flow cannula. So about 30 case experience, and they were able, the success rate of high flow nasal cannula was almost 60%, and that's exactly what we're experiencing. This is what I got from a webinar hosted by CHEST just yesterday. And just maintaining an appropriate seal is very important to prevent aerosolization. Using a surgical mask on top of the patient's mouth and nose will also help. Lots of resources available for the non-intensivist or non-critical care providers in the audience. So I urge you to look at the SCCM webpage for COVID-19 resources. The American College of Chest Physicians has also put out several webinars and podcasts to learn more about critical care management. Here's a COVID-19 marathon addressing several critical care issues that the European Society of Critical Care, Intensive Care Medicine hosted just a couple of days ago. Before I wrap up, quick reminder, these patients will require ICU admission because of management of acute hypoxemic respiratory failure. The pattern recognition for these patients is very important. So ARDS, early treatment, low tidal volumes, low driving pressures, high PEEP, sedation, paralysis, early proning, and thinking about their fluid management, running these patients as dry as possible. If these patients do develop AKI, there is a select, well-selected patients are going to benefit from replacement therapy. Thank you very much for the opportunity. I will stop here so we have some time for Fawaz's presentation as well.
Thank you very much, Neha. Fawaz, are you there?
Yeah, I'm here. Can you see my screen?
Yes.
Okay, perfect. All right. Neha left me with like 9 minutes. All right, so we're gonna try to go through this real quick. We're gonna talk about viral therapeutics and neurovascular implications, how this affects us as individuals and physicians in the neurosciences. I don't have any relevant disclosures. Most of this, what I'm going to try to go through this as far as like therapeutics is to separate the signal from the noise, tackling pertinent issues as far as medications and what to start first. needless to say, it's very challenging to start to develop and identify the antiviral that you need to that's going to work, because you need to target a specific part of the virus life cycle, as well as necessary for it to reproduce. Also kill the virus without killing the human cell that it occupies. Problems with viruses like this is that they're highly adaptive, they reproduce very rapidly, and they mutate with each generation. Hence, you develop a lot of resistance. Steroids, a little bit controversial, have been associated with an increased risk of mortality in some cases with influenza and delayed viral clearing with the MERS-CoV virus. Although widely used in the management of severe ARDS, there's no good evidence for benefit. A limited role for the WHO and the CDC recommend glucocorticoids not be used in patients with COVID-19 pneumonia unless there are other indications. For example, exacerbation of chronic COPD. As far as NSAIDs are concerned, some clinicians have suggested the use of non-steroidal anti-inflammatories early in the course may have a negative impact on disease outcome. Based on anecdotal reports of a few patients who received NSAIDs early in the course and experienced increase in the severity of the disease. A lot of these concerns, we've been trying to limit this, and if anything, using Tylenol for fever control as opposed to like NSAIDs. So we have a lot of investigational agents. Many investigational agents are being explored, and an incredible number of trials are up and running and enrolling patients. I went on clinicaltrials.gov just to figure out exactly what we're dealing with. So we have essentially 9 completed trials, all of which are diagnostic and diagnostic, none are therapeutic. Then we have, interestingly, there were over the course of the past 3 days, this is a rapidly evolving disease process. Over the last couple of days, I noticed that we went from trials that were not yet active, but not recruiting yet. We went from 71 to 95 to almost 105 clinical trials over the past 36 hours. So the number of trials are increasing exponentially. I'm gonna go through this really quick. This is just a slide that shows like different medications from antivirals to antimalarial agents to antibiotics to ACE inhibitors, thalidomide, toliclizumide, hydrochloride, a few other medications, hyperimmune plasma, and there's one trial that I'm personally very interested in looking at, like in addition to all of these, like a trial that looks at, like there are individual trials looking at many of these interventions, but there's one trial that I thought was very interesting, which was looking at, it's called COVID Access, looking at chemoprophylaxis in exposed healthcare workers. We're going to talk about that very briefly. So as far as the medications that we're currently using, we're using based on observational series and anecdotal or extrapolated evidence. Remdesivir is a novel nucleotide analog that has shown some activity against severe acute respiratory syndrome, or SARS-CoV-2, in some animal studies. It's currently available via compassionate use in children and pregnant women as of 3/24/20 through Gilead, an investigational new drug application. There are case reports of one of the first few patients with COVID-19 in the United States with some benefit to this. Although when remdesivir was tested with Ebola, the results were not favorable, but the clinical safety profile in humans appears reasonable, and I don't think it's unreasonable to trial this. Chloroquine, hydroxychloroquine, I think most institutions are currently using. The use of chloroquine in treatment guidelines from China Commission was reportedly associated with reduced disease progression and decreased duration of symptoms. In an open label study of 36 patients where they received hydroxychloroquine plus azithromycin, there was an increased rate of undetectable SARS-CoV-2 RNA on nasopharyngeal specimens. The combination of azithromycin and hydrochloroquine appears to have additional benefit, but there are methodological concerns about the control groups for this study. To move through this real quick, as far as azithromycin is another medication that we've been trialing, especially at Westchester, in addition to hydroxychloroquine. due to the limit, basically we have a very we have one trial, very small number, but the results were pretty favorable, and it for the most part has a reasonable safety profile. One concern is the prolongation of the QT interval with hydroxychloroquine as well as with azithromycin. So have to factor this in and look out for this. Interleukin 6 inhibitor, tocilizumab, again, part of the China National Health Commission, has also been, is being evaluated in current trials. Lopinavir, ritonavir, these are protease inhibitors that have also been demonstrated to have some data indicating some in vitro and in vivo activity against SARS-CoV-2. But it's quite in SARS-CoV, but it's questionable whether this translates to activity and effectiveness versus SARS-CoV-2. Convalescent plasma is a potential option for treatment when there are a sufficient number of people who have recovered and can donate high titers neutralizing immunoglobulin containing plasma. In general, the passive immunity is better at the onset of disease or as prophylaxis. So technically, if this is to be given, it should be given within the first 3 days or even prophylactically. One study that looked at convalescent plasma showed 3 patients with SARS were treated with 500 ml of convalescent plasma, resulted in reduction in plasma virus titers. And in another study in South Korea showed that only one of the 2 had titers high enough to actually produce a meaningful serologic response after the infusion, which highlights another issue that we're probably going to face, which are neutralizing antibodies. And we have to factor in that some of the people who recover from viral illness may not necessarily have high titers of neutralizing antibodies. COVID access is about to start enrolling in the United States. It's primarily started in Europe. The rationale is PPEs, as Neha mentioned. It's actually the body, like it's one of the least protective interventions. From the experience in China and Italy, approximately 4% of all the patients were healthcare workers. It will take at least a year before vaccines are available. So this study basically looks at runs 2 distinct independent trials: COVID Access 1, COVID Access 2, randomizing healthcare workers involved in the management of suspected or confirmed COVID-19 cases. One will study hydroxychloroquine versus placebo, and the other will look at lopinavir, ritonavir versus placebo. And they're looking for approximately 1,200 patients, 600 patients for each trial. At Westchester, we have a 3-tiered treatment approach for mild disease, and patients meet indications for treatment. We typically start hydroxychloroquine and azithromycin. For moderate disease, we will start, patients will be on hydroxychloroquine and azithromycin, and we will add lopinavir, ritonavir at a later stage once they deteriorate. For severe disease, which is progression of disease in the to first-line therapies within the first 72 hours, we'll continue with hydroxychloroquine, azithromycin with or without lopinavir, ritonavir, and compassionate use of remdesivir. In cases where the interleukin 6 level is high and the patient is not a candidate for remdesivir, we will use tocilizumab. Wanted to touch base really quickly. I know we're nearly done here. Just to talk about the neuroinvasive potential of SARS-CoV-2, cell entries through ACE2 inhibitor, ACE2 receptors. There's increased evidence that shows the coronavirus may actually extend beyond the respiratory tract and invade the CNS with an affinity towards the brainstem. Signs: headache, nausea, vomiting. Patients have actually demonstrated spread by synapse-connected route to the medullary cardiopulmonary centers, from the mechanoreceptors and chemoreceptors of the lungs and lower respiratory airways. It kind of remains unclear whether the potential for invasion of the medullary cardiopulmonary centers is actually partially responsible for the development of acute respiratory failure in COVID-19. So it's important to see the forest for the trees. Are these patients who are in ARDS and rapidly progressing to coma, is this because of an underlying neurologic invasion? It's not entirely clear. I don't think we have the data to suggest that. There are, just yesterday, there was a case report of an acute hemorrhagic necrotizing encephalopathy secondary to COVID-19. There are other smaller case reports of GBS and ADEM secondary to this. there's an abundance of data that says that anosmia, hyposmia, and dysgeusia occurs in approximately 30%. I saw a study yesterday that said it's approximately 70% of patients who will develop severe disease will have these symptoms before that, which again indicates that the site of entry may actually be causing this. Neurologic manifestations in Wuhan, and I thought this was two really interesting slides. Between January 16th, 2020 to February 19th, 2020, 214 patients were identified in I believe it's Union Hospital. They found that acute strokes or cerebrovascular disorders occurred in 5%, and 5 out of 88, which was 5.7%. 5 strokes in the severe group. There was actually 1 stroke in the non-severe group, which is approximately, so 6 out of 214, which is approximately 2.8%, which is actually very high, with impaired consciousness occurring in approximately 15% and skeletal muscle injury in approximately 20%. In another study published by the same group of 221 patients, they found that the stroke, acute ischemic stroke, was approximately 5%. This is 11 patients as opposed to 5 patients or 6 patients like in the other trial. Mortality rate in the ischemic group was approximately 38%. Patients with strokes were noted to have more severe inflammatory infections, or more likely to have elevated inflammatory markers in the state of a high coagulation state. 3 were cardioembolic, 5 were large vessel stenosis, and 3 were lacunar strokes. Obviously, a lot of limitations. Both were published in Lancet and Lancet Neurology. What's interesting is both same groups, same hospital, same time period, actually same authors, 221 versus 214 patients. This actually was highlighted to me by a colleague of mine, Jim Siegler, in his podcast. And the incidence of was 3% in a paper dedicated to neurologic complications, but in another paper dedicated to stroke, the investigators somehow added 7 patients. I'm not sure how to analyze this information. How were they able to add the 7 patients to enrich their population? I believe the data needs to be validated. I could tell you in our experience, and Chris and the folks at Sinai may corroborate this, the number of stroke patients, if anything, we've noticed has decreased. Based on this information, we should expect approximately, like in this past month, 3.7 thousand strokes, which is definitely not the case. Our colleagues from Europe are also stating that. And I reached out to a colleague, Dr. Zhao in Wuhan, who actually also said that he feels that the numbers of strokes were decreasing. Actually, he's in the main tertiary care center there, and he believes that the numbers are also decreasing. So I'm not sure how to interpret this data. I would take it with a grain of salt at the very least. As Dr. Betterson said earlier, everything has a silver lining. I think this is, in a way, allowed for the successful implementation or jump-started telemedicine care. I think that's going to become the new standard of care going forward. Unprecedented improvement in quality improvement. It's allowed us to identify holes in our care, in the care that we provide patients. It's reduced pollution, 25% less greenhouse emissions, at least in China. This may reverse very quickly once things are up and running. And it's actually improved social connections and a sense of family, all by virtual. Interestingly, my daughter had a poetry competition. She actually wrote her poem is #stronger than COVID-19. Very interesting that children are now actually starting to talk about diseases that affect us, but a portion of the poem that really affected me, where she's talking about how patients are dying and due to a virus made of a gene, and how she actually has heard me on the phone talk about who gets a ventilator and who gets an ICU bed, which is surreal actually to think of my daughter's talking about things like this. If anyone's interested in learning more about this, please listen to Neha and I just recorded our podcast. It's the Neurocritical Care Society podcast that is available for free on, I guess, wherever you get your podcasts. We're still learning about this. Desperate cases, desperate remedies. Hopefully we'll be able to overcome this. A lot of work ahead. All right, thank you.
Thank you. I believe you can hear me now. I wanted to thank everyone for participating today. We had upwards of 300 people coming in and out, and I think we all learned quite a bit from this. Fawaz, please mute. Can you please mute, Fawaz? I welcome the opportunity to follow up. If there are people who have questions or comments that they would like to get back to us on, if you have ideas for future collaborative grand rounds, Chris Kellner and I are open to this possibility going forward. So I thank everyone and look forward to seeing you at our next meeting.